Hi, my name is CJ Devgan, and welcome to season 2 of Breaking Barriers. My goal for season 2 is to discuss how digital transformation is redefining how care will be provided in the next 5, 10, and 20 years. I will be talking to leading minds in the healthcare sector and exploring how new disruptors are leveraging technologies such as artificial intelligence, population health, blockchain are reshaping the healthcare universe.
Hello and welcome back to another engaging episode of Breaking Barriers. My guest today is Eric Gombrich. Eric is a 30-year veteran in health technology, having worked around the world in bringing innovative solutions to market. He moved to Canada from US about 20 years ago and is a dual citizen with deep familiarity of both countries' healthcare system as well as having worked in those in the UK, most of Western Europe, Japan, and Australia. Welcome to the show, Eric. How are you doing this morning?
I'm doing great, CJ. It's a pleasure to be here. Thank you.
Fantastic. Would you like to add to your experience and background? And may I also request you to share a fun fact about yourself with our listeners?
I don't have much to add to my background. I think other than indicating that I've, for the most part, spent most of my time on what we would refer to as the private sector side of things. But I did have the occasion of working with one of the largest not-for-profit health systems in the United States, who were trying to commercialize many of the innovations that they were developing in-house to be available to other healthcare organizations. And so I got to see things from the inside, at least in the US, of how decisions are made. And that was a really eye-opening and learning experience. The only other thing I could say is, as much as I am passionate about healthcare, I probably overindulge in some of the great food and the wine that's local to the area I live in, which is the Okanagan Valley. And so that's probably the most fun fact about me. I'm a pretty simple guy.
Excellent. Back to our main topic. How do you envision care will be delivered in future? Let's keep 15 to 20 year horizon. But before we talk about the care being delivered in 20 years, let's talk about current state of our healthcare system. And when I'm talking our healthcare system, I'm mostly primarily focused on Canada. But yeah, I understand some of the challenges are similar that we encounter in Canada with US and UK and Western Europe, kind of a thing. But primarily our audience, our listeners are Canadian focused.
Sure. I think the biggest challenge I see, in the Canadian system is really related to the fact that, using my vernacular, it's somewhat trapped right now by the political process. We live under the auspices of the Canada Health Act, which has various interpretations as to allowing such things as privatization and whatnot around the system. And the general belief is, at least from a political public perspective, that those things are not allowed, that privatization is limited in what we can do in Canada. And I think there's a real challenge for any of our leaders to effectively step in front of the camera or grab a microphone or speak to the press and talk about making substantial changes without their opposition doing the same and talking immediately about how there's an attempt to whittle away at services and taking healthcare away. And that causes politicians to just be afraid of making the bold changes that need to happen. And it's not their fault. It's just we're kind of trapped in this quagmire. And I think that's probably the biggest issue that we have in Canada as far as making substantial change.
I hear you and I completely agree with you that we need to have an open, candid discourse on this subject. But even if we go beyond Canadian boundaries and borders, and you have a lot of experience in the US, the way healthcare is being provided universally, we still are using processes that were developed in 19th and carried forward into 20th century. We still are very brick and mortar kind of systems. Yeah. We still have to go and visit a physician, be seen by a physician before they will prescribe anything for us. Then the whole process, right? And And it's very time consuming. So why do you think even universally these things have not been shattered to date?
I think generally speaking, CJ, I think biggest issue is it comes back to remuneration and how, the physicians and other clinical stakeholders in the process are paid for providing their services. Even most recently, in the context of telemedicine or telehealth, which of course is an explosive, new model or paradigm on a global basis. Places like Texas, it was only recently, about a year ago, that they effectively changed the laws, forced by the government in Texas, to allow physicians to provide care through telemedicine without having a pre-established relationship with the patient. So in other words, the patient would actually have to go see the physician and have a relationship with that physician, effectively be on their roster before that physician could interact with that patient through telemedicine. Quite honestly, the reason for that, in my exploration and my conversations with folks, while it's perceived to be about the clinician wanting to know the patient, it was really set up as a barrier to entry to prevent telemedicine companies from beaming into Texas from outside of Texas to serve the population of Texas. It was a protectionist move, so the physicians would not lose market share in Texas. And that all comes back to the fact that they were protecting their incomes. And I'm not suggesting that they're not passionate and interested and focused on doing what's best for their patients, but I think we see all kinds of examples like that across the whole healthcare ecosystem in Canada as well. My big rant about this is, if my 5-year-old wakes up in the middle of the night with a sore throat, I don't necessarily feel like I need to take him to the physician. I probably could take him right to a laboratory and have them swab his throat with a nurse or a nurse practitioner there to look at his tonsils to see if that's what it is. And until the culture comes back, there's not going to be much for the physician to do. But we're forcing, because of the way that the physicians are paid and the way we set up the rules and regulations around the system, we force me as a patient to go to that physician and bring whatever my child may have into that physician's waiting room, potentially risking other patients there and making things more inconvenient for me. And those are the type of things we need to fix. And so I think it really comes back to, like I say, how things are paid for and the regulations around what physicians are able to do that are in the way.
And I'm in total agreement with you, violent agreement with you. The challenge that I'm still trying to understand is, like, even in US, they are not doing this thing, right?
Well, they are. They're certainly starting to, and there's all kinds of work being done. For example, Kaiser is a really good example. Kaiser will allow a totally closed ecosystem where they are both payer and provider. And so they not only have an interest, of course, in quality, but they have a very, very high focus on cost savings and efficiency. And so there are numerous places within Kaiser where I could go directly to the laboratory and they have a nurse there. These are models that were tested and are in place in the UK as well. And so it really comes down to us harmonizing how things are paid for against how they are delivered. And I think it's one of the key things that we lose in the conversation, because it's very complex to explain this in a 30-second soundbite on the news. We need to separate how are we paying for things from how we are delivering things. And we need to work on both sides of that equation.
I agree with you. So let's go to our follow-up question. Single payer versus multi-payer system. So you have some exposure to multi-payer systems that we keep referring to as US in our conversation. Yeah. In Canada, more or less, is a single payer, though people will say we have 13 payers because every province is actually a payer. But in essence, we have, if you're living in a single province, which most of the case, healthcare is very geographically centered industry. So within that industry, there's a single payer. And if there's a single payer, for example, I'm talking in context of Ontario, OHIP is the single payer, and costs are actually incurred by the taxpayers. So there should be a bigger incentive in things like capitation, physician, and things like that. Why they haven't taken place other than political will? Why are people not demanding it?
Well, I think they actually are starting to, and I, again, I think not to attack the words that you've used, but they're very common. And I know that you're speaking in the context of an audience that's probably very familiar with our subject matter, but I don't think there exists anywhere truly a single payer. I still pay something out of pocket. I pay for my medications. I pay for my dentist. I pay for my eye care. And even in the case of OHIP, this is why we have supplemental insurance that's out there. And so what we're talking about is having a single payer that's covering a basic set of services, which changes obviously, over time, generally speaking on a 3-year cycle in Canada in a provincial context, what's being remunerated for. But I think as we're seeing both the out-of-pocket expense and the services on that list diminish, and so I as an individual am taking more and more financial burden on for the health and wellness of myself and my family, I am starting to get more vocal. I think my friends and colleagues and neighbors and family members and people in industry that I know, they are starting to pay more attention to this. And as you and I talked about in a previous conversation, I was just having a conversation a couple of weeks ago with a gentleman that decided to pick up and go to Mexico for his knee replacement and pay $9,000 out of pocket to do it because he is still income earning. And the wait time to get it done through the provincial system, he wasn't, he found it to be worth the $9,000 to go down to Mexico and have it done. And it was done by a Harvard-educated surgeon. And so I think we're starting to see people become more active, proactive, and vocal about these things. And I think, quite honestly, that's what's going to become the tipping point here in Canada, is when enough people start doing this, it's going to force that bigger conversation.
Yes. And to that point where we're talking about multi-payer system or two-tier healthcare, and I think it is a tabooed word in Canadian context. I think a couple of provinces have tried a bit, in more limited fashion, privatization of some services being given, because I know my cousin had a knee injury and the wait time here to do an MRI and everything was 6 to 8 months. So he just went over to Buffalo and got all those things done and got his treatment in Buffalo.
Right.
Now we have taken money out of a Canadian economy and given it to US. Not that I'm against anything like that, but why can we not create those second-tier care providers within Canada so it is more convenient for our citizens? What are the challenges with that?
Well, I think it comes back to, the Canada Health Act and the interpretation of that. As we like to say in the industry, we need to have the quote unquote adult conversation. We do have a two-tier system. The fact that I can go to my physician and it doesn't cost me anything and he writes me a prescription is great. But if I can't afford to fill that prescription and the next person in his exam room can, that's a two-tier system. And that's the reality of what we have right now. And we do have that privatization. Our dentists and our optometrists all operate in that model. They're other than for children in most provinces, they're not covered as a benefit in the provincial health plans. And so, again, I know people that haven't been to the dentist in more than a decade because they can't afford to do it. And so we do have a two-tier system, and the sooner we actually have that conversation and accept the realities of it, the sooner we can get on with fixing the problem. But right now, we don't want to go there because, again, the politicians, I think, are trapped. If they bring that subject up, they get eviscerated by the opposition, for having these views that are counter to what we hold near and dear to our hearts as Canadians.
Yes. So let's go back to our main subject. We have digressed a bit, and we have 10 more minutes on this show. So, future of healthcare. So, what do you see? And I don't want to talk about artificial intelligence or telemedicine, because there are a couple of episodes that are focused primarily on that. But
sure. From
where we are today, and given the background you have, especially last time we spoke, we talked about NHS and how they have changed and providing universal health, but at the same time providing more accountability to providers. So let's talk about actionable baby steps if you were made health minister of Canada, if you were that in that role, what would be actionable steps that you would take
Yeah.
over the next 4 or 5 years?
Yeah. So, the first thing is, if I was made health minister, and this, gets to a personality type of thing, I would probably go into the position knowing that it's a short-term thing. And the reason is I would force this conversation we were just talking about. And I would embrace it knowing that I will effectively be, as I said before, eviscerated at some point and run out of office. But hopefully I will set a ball in motion through that. But the actionable steps is I would start to recognize that what I think we're seeing happen globally, as well as in Canada, is a deconstruction of the historical, as you said, bricks and mortar system. We're seeing Loblaws and all of its sub-brands, get more involved in healthcare and open clinics in their stores, in their historically what were grocery stores. We're seeing them start to get, much more involved in pharmacy, through their acquisitions. And it's not just Loblaws. It's Walmart. It's everybody that is approaching this from a completely different perspective. And at some point, as consumers, as I am expected to take on more of a burden on some of these things, I'm going to reach the point where I say, simply out of convenience, rather than go to the hospital and have it covered for free, I'm willing to pay the $25 or $40, to do the clinic at the grocery store and have my prescription filled while I do my grocery shopping, because it's just going to save me so much time. I don't have to pay for parking. I don't have to pay for transport. I don't have to take more time off of work, all of these type of things. So I think the consumerization is the major thing that's happening. And so I would focus on trying to realign as health minister, enabling that and embracing that reality and empowering the current structure, physicians, nurses, nurse practitioners, et cetera, to be compensated appropriately, to participate in that model, and allow them to do things like offer telehealth and be paid for it, and allow me to take my 5-year-old directly to the laboratory without it taking money out of my GP or my family physician's pocket. These are the disconnects that I think are creating barriers to this type of stuff.
Oh, fantastic. So we have 7 more minutes. I don't need all of those 7 minutes. If there is any last minute things that you would like to share with our listeners.
Yeah, I guess, given that we've got a couple more minutes, just kind of building on that theme, I think the other thing that we see discussed substantially, and I just saw that Ivy and Schulich are offering now a seminar on this. It's not a promotion for them. I have no vested interest in their success, but I was just provided an invitation for a course or a series of seminars that they're doing on population health. And I think that's another theme that we're seeing. And really what it comes back to is transitioning from a model of episodic reactionary sick care to a more proactive model of preventative care. And again, the way that our whole system is set up, the way that everybody is paid, particularly physicians, is not aligned with that. They are paid to deal with me when I'm sick, not deal with me to keep me well. And, to the point, the question you asked a few moments ago, when I become health minister, I would be looking at incenting physicians to do that. I would be looking at models that say the majority of GI problems for patients start in the mouth. So why don't we have dental coverage, for everybody? We should be paying for just general checkups for people's mouths and teeth. Because as their teeth go bad, they start eating poorly. That contributes to the diabetes explosion, the GI problems, et cetera, et cetera, et cetera. But it requires a massive overhaul on how we pay for things.
Absolutely. Population health is a subject which is very near and dear to my heart. Back in 2007, I actually built a solution that would collect data from point of care systems, create a longitudinal record, and provide more informed solution to providers at point of care. So that was an old technology, which now basically we call population health. And we will focus one whole episode on population health. We will share with our audiences what we actually mean by population health and what do we mean by fee for service, which is episode versus more value-based, where especially in an environment like Canada, where healthcare is paid for by taxpayers in a pooled fashion, it makes more sense to look at the total cost of providing care than providing care per episode. So we will spend a full episode on this subject and talk about pros and cons of it. But I really appreciate, Eric, your time and sharing your candid views. I know we have opened up and raised some difficult topics that a lot of people do not want to even discuss in Canadian context. But I think with our growing population, with our aging population, I think it is time to look at healthcare from a different set of lenses. We cannot keep on providing care using processes that were developed and designed in 19th and 20th century. We need to look at 21st century technologies to transform our healthcare system so we can take better care of our population.
Yeah, I totally agree. And I guess as kind of a closing point, I don't think anything I've said today, and I really appreciate the conversation, is novel. I don't think anything I've said are things that, the current ministers of health across the country, as well as our federal minister, don't already know. The challenge is, how do they do it? And that's why my opening comments were about the challenge of being trapped in this political environment. I think we have to find a way of allowing this, both the conversation and the change, to happen safely, so people don't feel that their careers and their reputations are at risk. Because as long as that's what's the situation, we're not going to make progress, other than just letting the consumerization drive everything. And our health system, the ministers and the administration, will lose complete control in that process. And so I'm excited to see how things play out in the future.
Absolutely, 100%. I agree with you. That nothing that we are discussing is a brand new concept. We are not inventing anything on this call. Yeah. We are merely discussing topics and solutions that have been designed and developed by leading minds, both in Canada and abroad. And it's just the will and the leadership. I remember Mike Harris. I don't know if you remember Mike Harris. If you were, he was a premier of Ontario in 90s, and he did some major transformation work in mid to late 90s, and he was actually closing hospitals, which was not a very welcome move by a lot of people. And I didn't know a lot of these issues at that time. But we need someone with common sense and say, okay, we need to use our common sense to define solutions for our system.
And I totally agree. And that trend has continued around the world. Other countries are closing hospitals in lieu of polyclinics and things like that, where they are putting a dentist and an optometrist in the same building as a group of GPs. And so we are seeing this innovation happen. We just need to pick up the pace.
Yes. So we are right at the top of the hour. I appreciate your time, Eric. We'll definitely have more conversation, both on the record and off the record. Okay. I really appreciate you taking time out of your busy schedule and meeting us early morning, your time. You have a wonderful and productive day and great weekend.
You as well. I've enjoyed the conversation, and we'll talk soon. Take care, CJ.
Thank you.
Bye-bye.
Bye-bye.
That is all for today. Thank you for listening. If you are a healthcare executive and grappling with challenges to transform your organization, contact me and let's talk. If you like our show, please subscribe, leave a rating and a review for us on iTunes. Ciao and have a productive week.